I think we're.
Sorry, go ahead.
Is this the first slide of your presentation?
There are a couple of slides that come in automatically with grand rounds that I can go through at the beginning.
Okay, I'll go ahead and read the content, and if you'll just do the clicking for me, that would be great.
Absolutely.
Thank you so much. Okay, everybody, welcome to this afternoon's Grand Rounds presentation. It is May the 5th of 2021, so happy Cinco de Mayo to everyone who's connected. The event ID for today's presentation is up on the screen. It is also in the chat, and the number for today's event is 125047. And then, of course, there are all the different ways to go about using today's presentation to get your CME credit. So please make sure you do that. Before we get started, thank you everyone for muting your microphone once we have begun. Please be attentive to the presenter, and today it is Dr. Adrienne Roth. Be engaged in the session and complete and submit a session evaluation form at the end of the presentation. Our Grand Round series is also in collaboration with the South Texas Regional Family Medicine Grand Rounds. Our educational partner is the South Central PHEC, and our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. These are going to be the steps if you need to have access to any of your CME transcripts. You can visit the CME office's website and then follow steps 2 and 3. If you have any questions about it, please contact the CME office directly. For AAFP credits from the American Academy of Family Physicians, please ensure you have your AAFP ID number. This live activity, today's presentation, has been reviewed and is accepted for up to 1 credit by the AAFP. Physicians should claim only the credit with the extent of their participation in the activity. And if you have any questions about this, please contact the AAFP directly. Dr. Roth and Dr. Palacios have no relevant financial interests or commercial interests to disclose for today's presentation.
Okay, well, I can start here. I will be able to see the chat. So if you have questions along the way, feel free to interrupt me and speak up, or you can put them in the chat and I can see it. My presentation today is one of the top poems of 2019, normal vital signs and pulmonary examination results essentially rule out CAP, community-acquired pneumonia, in adults with acute respiratory infection. Again, my name is Adrienne Roth. I'm a PGY3, for those of you who don't know me, and Dr. Palacios was my preceptor for this presentation. There we go. Okay, so the objectives of this presentation: identify a clinical decision rule, also called CDR for the rest of this presentation, in practice for diagnosing or excluding community-acquired pneumonia. Evaluate how normal vital signs in a normal pulmonary exam can essentially rule out community-acquired pneumonia for patients complaining of respiratory symptoms in the outpatient setting. Compare vital signs and normal pulmonary exam to the gold standard of chest X-ray. So for some background, the annual incidence of community-acquired pneumonia is 25 to 36 cases per 10,000, depending on who you ask. In 2015, there were 1.6 deaths per 10,000 persons of community-acquired pneumonia, and when combined with influenza, it's the 8th leading cause of death in the United States. When you pull them apart, it does go a little bit farther down, but when you combine them together, it's the 8th leading cause. And the recommended test currently for diagnosing community-acquired pneumonia is a chest radiograph. So community-acquired pneumonia is a significant source of morbidity and mortality in the United States. There were over 50,000 deaths due to pneumonia. That's the 1.6 per 10,000 number. The reason that this has been looked into is we can use that gold standard radiograph for diagnosing pneumonia, but if we were to do this on all of our patients in the outpatient clinic setting that showed up with acute cough and other concerns, that would be costly, inconvenient, and expose our patients to far too much unnecessary radiation. So this systemic review, it was a systematic review of articles published in Medline, was the source they used from the inception of Medline through January 2017 that were attempting to diagnose, predict, or rule out CAP as an outpatient. There was they ended up reviewing over 900 studies and were able to narrow it down to only 12. They assessed these studies for bias using a quads 2 score and categorized the studies they used in either low, medium, or high risk of bias. 6 of the studies they used were low risk of bias, and the other 6 had some limitations, and those were due to moderate risk of bias. One of them was considered biased because it was a prospective study, but they did enroll patients prospectively and then track them afterwards. There was one study where not all of the patients received the standard, which is a chest X-ray. And there were 3 other studies where, again, a chest X-ray was ordered because of suspicion of pneumonia, but not necessarily, not all of their data was exactly consistent. So that one was not included in the final, but they used it for reference. The inclusion criteria for their studies were a chest X-ray or CT scan that as a primary reference point. They wanted them to be prospective studies. They wanted only adults and adolescents, and they wanted outpatient clinic or emergency room settings. They excluded people who, or excluded studies that were looking at hospital-acquired or ventilator-associated pneumonia, immunocompromised patients, and special populations such as nursing homes or military. So of the 12 studies, this is a kind of just review of them. Almost all of them were prospective, as you can see. About half were in the emergency room setting and half were in a clinic setting. None of them were that recent, which is I think important to look at. About half of them were in the 90s or before, and then the second half were in the early 2000s. They all had pretty decent sample sizes, and all of them were at least over the age of 15. Of note, only 5 of them were in the United States, and the rest were from other countries. So clinical decision rule. The clinical decision rule is an algorithm, point score, or simple rule of thumb heuristic that categorizes patients as having a risk for a disease. And having one of these for pneumonia is kind of part of what the study was looking into. So we can start by saying, what are the signs and symptoms that we can diagnose someone with community-acquired pneumonia? Of the studies that we looked at and just kind of the general practice, the 4 most frequent symptoms were, in addition to a patient presenting with cough, were elevated temperature, heart rate, crackles on auscultation, and decreased breath sounds. Elevated temperature was the most common, and this is in patients that are presenting with a cough. So cough is the given, and these are the 4 other most frequent symptoms. So for the outpatient primary care physician, especially one that doesn't have ready access to chest radiograph, ruling out CAP with one of these rules or with physical exam would be a very powerful tool to have. So this is another look at the studies that were included, which is just reiterating that what associated symptoms along with the cough were included in each of the different studies. Something that is interesting about this is if you look at the temperatures, they're in Celsius, so 37.8 and 38 are 2 different cutoffs that they had. And so the patients that are 38 are at 100.4 degrees Celsius. So the 37.8 is actually lower than what we would necessarily consider a fever according to SIRS criteria. The pulses are 100, so then SIRS criteria again is over 90. And then the respiratory rates are 20, which is equivalent with the SIRS criteria. And then there was that one study that used 25. So I just thought that was interesting that, especially in the emergency room setting, these patients could show up and are meeting SIRS criteria. And if you're getting that in the office, then that's something that's pretty worrisome, that might kind of change your decision making. So just to highlight the 3 studies that did have point-based clinical decision rules that they created. So Deere et al., they gave point systems for associated symptoms associated with, of course, the baseline of showing up with a cough. So rhinorrhea and sore throat actually got you negative points, so less likely to have pneumonia, but night sweats, myalgia, sputum all day, so copious sputum, respiratory rate greater than 25, and 100.4 temperature or more all got you extra points. They found that patients with a -3 to 0 score had a likelihood ratio of having pneumonia of 0.47, and which is a 1.2%, correlates to the 1.2% probability of CAP with the baseline prevalence of 2.6. The high-risk group, which had a score of between 2 and 6, had a 27.3% probability of CAP with a likelihood ratio of 14, again with the same baseline prevalence of 2.6. So that is a significant difference that they had. So that's why they were using these kind of point-based systems. Another one that had a similar point-based system, Heckerling, they used a derivation set from Illinois, and then actually used 2 other sets from other locations to validate their point system. So here, you got 1 point for each symptom on there in addition to the cough. So if you had 0 or 1, you were in the low risk of CAP category, and that was a probability of 4%, given their baseline prevalence of 29.2% and likelihood ratio of 0.19. So their prevalence was much higher because the prevalence in the first study, they were looking at just general prevalence in the population, and this 29% 2 prevalence, they were looking at patients presenting to the emergency room with a cough. So they were more likely to be diagnosed with pneumonia. The high-risk group got 0.4 or 5 positives of those symptoms of fever, pulse greater than 100, rales, decreased breath sounds, absence of asthma as a chronic condition, and they had a 64% probability of CAP with a likelihood ratio of 8.3. Our third study that used a point-based system was Van Voigt. They also incorporated a CRP, POC CRP test as part of their point-based score. So you got points for absence of runny nose, positive breathlessness, crackles, diminished vesicular breath sounds, fever, tachycardia, and then in CRP elevated above 30. So for them, their low risk group had a 0.7% probability of CAP, and their prevalence they were using was 5.2, and their likelihood ratio was 0.14. Then the moderate or high risk groups, which I believe they had a score of to be moderate to high risk, I think you had to have 3. I don't have their prevalence on here. I apologize for that, but their likelihood ratio was 4.3 for the high risk group and 0.76 for the moderate risk group. So theirs was a little bit thinner. So the moderate risk group wasn't really telling us much difference. But if you look between the low risk and the high risk, then you did see a difference in likelihood of community-acquired pneumonia. So this is just a breakdown of what we just talked about for the 3 different point-based rules. And so this is some of the numbers that I didn't have included. You can look down at the Van Voigt, the high risk group greater than 3 was a 51% prevalence of pneumonia in that group. So these tools could be quite helpful. So the CDR we were looking at was normal vital signs accompanied by no findings on a pulmonary examination rules out CAP well, considering those 3 different rules. Those 3 studies, if you pooled their likelihood ratios for the low risk group, they have a pooled negative likelihood ratio of 0.09 to 0.11. Their pooled sensitivity was 0.96, and I think the overall negative likelihood ratio, that's for all of the studies, was 0.1, and the area under the curve was 0.92. So not bad. One problem that we had here is they didn't have whisker plots on these, which those 3 studies didn't have a huge amount of data, and they didn't have them included. So I think that's part of why that wasn't in there. One study of note that I don't have that isn't in this table but was included in the paper was Stoyer et al. They used a different CRP threshold than Van Voigt. So they were saying CRP less than 10 can rule out pneumonia, or 11 to 50 with no dyspnea and no fever could also effectively rule out pneumonia. So that was an interesting thing too that was included. So their clinical decision rule that they were looking at, which was the CRP, they were able to reduce in their population antibiotic prescription by 9%. And that was just kind of something that was mentioned in this study that they couldn't include in their pooled data because it was just built a little bit differently than the three other main studies. So a little bit more about our results. So what we see is that what we had said before, this likelihood ratio of 0.09, negative likelihood ratio for low risk groups helps us effectively rule out pneumonia in the clinic setting. And so this is just kind of a reiteration of that data in chart form. So I think that this was something that kind of just validated what I feel like we have learned when we are taking care of patients in the clinic setting. And it's always good to know that your good physical exam and interview of the patient really can do a lot, and you don't necessarily need imaging. It's so easy just to reach for imaging nowadays because we do have it, downstairs in our clinic. But this study helped help to reiterate that when we do hear someone coming in with a cough and they're coming in with complaints and they're concerned, they're saying, doctor, I think I have pneumonia. When you do know that they don't have a fever and you aren't hearing anything on exam, and maybe they have a runny nose that makes them less likely to have pneumonia, you can confidently say that it is very, very unlikely that they have pneumonia, and you don't necessarily need to get a chest X-ray. So this was something that I found interesting, just to kind of validate our physical exam skills that we rely on. So one thing to note that I kind of touched on earlier is including CRP as an initial evaluation could be promising, but we definitely need a lot more studies on this. There was really just the 2 studies that included CRP, and one of them was equivocal. And this study, Stoyer et al., kind of alluded that we maybe could be able to use CRP as a laboratory evaluation instead of radiography to rule out pneumonia in our clinic patients. Something else that I just wanted to bring up at the end is, just as a reminder and an education point, what about procalcitonin? So I think this is something I thought of briefly right at the beginning before I started really diving into this topic, is I was like, well, what about a procalcitonin? But all of the studies that we have on procalcitonin is, first of all, it's a tool to discriminate between viral and bacterial pneumonia, and it's primarily studied and used in the inpatient setting. So it's not really a great correlation with our outpatient setting, or really for outpatient in deciding between bacterial or viral infections. So that is important, because if we were to see someone in the clinic and want to rule out pneumonia and we did a procalcitonin and it was negative, they could still theoretically have a viral pneumonia. So that's something that's important to think about. This is really a tool for inpatient use, and for once someone already needs to come in for treatment, how to decide on antibiotics. And on top of that, the negative predictive value is only about 72%. So that's decent, but it's not as good as we would want it to really be confident to not do antibiotics, or confidently say somebody doesn't have a bacterial pneumonia in the outpatient setting. It is also a tool that's used with multiple draws. So if you remember from our inpatient, we will draw it when they get into the hospital, and then you can draw it 48 hours later as a comparison. So just to note that this is not necessarily, it's not necessarily relevant to us in our outpatient evaluation of potential pneumonia. So these are my references, and I don't think, oh, I missed one. I don't think I got any questions in the chat. What questions are there?
Adrienne, this is Dr. K. Can you hear me?
Yes, sir.
So the first thing I want to point out is that, and I think you summarized this well, but the negative likelihood ratio of 0.1 is a decent negative likelihood ratio. The positive was something like 1.79, which is not a particularly strong positive likelihood ratio.
Right.
So the result is the lack of these things is pretty good at ruling it out. The presence of these things is not very good at ruling it in.
Right.
Okay.
Exactly.
So I just want to make sure everybody understands that. So if we can rule it out with a lack of these things fairly well, but we can't rule it in if any of these things are present. So
exactly. So if you're in clinic and you think someone does have pneumonia because they do have all of those things,
or even just one of these things.
Right. You do have to get the test.
Right. Okay. So that's the one point I wanted to make. Secondly, as you said, that they did do an assessment of quality of the studies.
Mm-hmm.
Did they look for whether the quality of the study correlated with the outcome of the study? And the other thing you made out is that there were 2 groups of studies, one that were done like in the 1990s, the other group that was done in the early 2000s. Did they look at whether your publication was related to the outcome as either?
They did not. We can just look at this. The three that they mostly looked at were Deer, which is right at the top, which was that says 1984. Heckerling was 1990, and then the last one was 2013. So the three that had the point-based clinical decision rules they did have one more recent one. But no, they didn't explicitly say that or address that.
Okay, what about the relationship between quality of study and the outcome of the study?
No, they didn't talk about that either. The three
that would have been important, right? If the really good studies didn't agree with the finding here,
right,
then that should cause you to wonder whether we can really trust these findings.
Right. So the three with the clinical decision rules were low likelihood of bias, though. So the ones I focused on were all low likelihood of bias, but they actually didn't explicitly address it besides that.
But they included all 12 of the studies, though, in their final analysis, right?
They included them all in the final analysis.
Okay.
Yeah. So the pooled data therefore may not be as reliable as when you look at those three studies individually. I see what you're saying there. Anyone else have questions?
Hey, Adrienne, it's Palacios. Great job on your presentation. I kind of wanted to, I guess Dr. K beat me to it with the first thing he brought up about this information being good to rule out, but not so much to kind of rule in. It kind of, when I was looking at some of the data, it made me think of like a D-dimer, right? You can use it to rule out a DVT, but you can't necessarily use it to I guess, rule in. So that was one thing. The other thing is that from a lot of the studies, it excluded the very young and the very old. So that's one thing to keep in mind when using this information in practice. And lastly, I want to use a plugin for point of care ultrasound, because I know they were using X-rays as the comparison method, but point of care ultrasound combined with vital signs and physical exam has a sensitivity and specificity for diagnosing pneumonia that approaches around 90%. So that's just another tool that if we get trained on, we can use to help our diagnosis.
Interesting. Yeah, that's a good point. Because the very young and the very old are the most vulnerable. So we might need to kind of take these with a grain of salt when we're considering those more vulnerable populations.
Adrienne, and actually, I guess this is a question for the entire group. In this day when we now have 2 pneumonia vaccines, have we ever looked at clinical decision rules that help you rule in or rule out pneumonia in people who have been previously vaccinated?
I didn't explicitly seek out that information, but that is a really interesting question. So I'm not sure. Something else to remember when on the topic that Dr. Palacios brought up about specifically our older patients is we do have another kind of clinical decision rule calculator that wasn't touched on in this, is the CURB 65 score. So if you have ruled them in and you have decided that they aren't necessarily relevant to being able to rule out pneumonia, you can use that to help your decision making on the severity of their pneumonia and what context they need to be treated in. That takes into account BUN, respiratory rate, their age if they're over 65, and I believe blood pressure, and there's one more thing. In the CURB 65. Ooh, it's the C, confusion. Any other questions?
I don't have a question, Dr. Roth, but I just wanted to mention to the group that I did include the link for the evaluation form for your presentation in the chat. So it should be there for people to access.
Awesome. Thank you so much.
Yeah, no problem. Great presentation.
Thank you. Thank you, everybody.
Thank you, Adrienne.
Bye, Dr. K.
Bye.